Welcome to, goodness, week 5 of PNR 204. Today we're going to go over chapters 23 and 24, and we're going to have 2 brief Kahoots, and then you guys, hopefully you read your announcement. You guys have a quiz today. So the quiz is very heavily focused on the information from last week. If you guys paid attention to the Kahoot from last week, then you should do fine on the quiz this week. So that'll be the last thing we do at the end of class. Does anyone have any questions they want to bring up before we get started? Okay, so I'm going to start with chapter 23, the sensory neuro conditions. So this is PowerPoint. I did send them to you. If for some reason you weren't able to open them, or if you had any problems, please let me know and I can resend them. So in this chapter, we talk about the eyes, the ears, and we also talk about the brain. So a lot of times you hear about kids having ear infections, and that most commonly is what's called an otitis media, but there also is what's called an otitis externa. So what do you guys think? What's the difference between an otitis media and an otitis externa?
Location.
Okay, so where when you have an otitis media, where's the infection?
In the inner ear, maybe?
In the inner ear. So it's on the other side of the tympanic membrane. And the otitis externa, where's the infection?
In the outer ear.
So between the tympanic membrane and in the ear canal. So this is the first thing that we're talking about. So it's an infection of the ear canal, so it doesn't go beyond the tympanic membrane. That's also called swimmer's ear, and it's pretty painful, but it doesn't normally require for them to take an oral antibiotic. They just normally irrigate the ear and then they put in drops. It's also called swimmer's ear. And then your lovely classmate, very intelligent classmate. So the otitis media is the inner ear or the middle ear. It's the part that's on the other side of the tympanic membrane. And this is the one that you're going to hear about more often when you're dealing with pediatrics. Kids get ear infections pretty regularly. It's not uncommon. And this is what the tympanic membrane looks like when they have an otitis media. So normally the tympanic membrane, this is what you're looking at here. Normally the tympanic membrane is like a pearly gray color. If there's no infection, it's almost like a grayish blue. And then when you have the infection, you can see this is red and bulging, and there's fluid behind here, and that's what's causing the pain. So there's a couple reasons why kids are pretty susceptible, but one of the main ones is that their eustachian tube, it's not as angled. So someone's not on mute that's talking. So could you make sure that you're on mute, or I can go through and mute people? Thank you. So the eustachian tube helps drain the fluid from the middle ear. So the eustachian tube of kids, young kids in particular, it tends to not have the same angle. So it's flatter. It doesn't have the same ability to drain. And that's the main reason that they are more susceptible to ear infections. So these are kind of some symptoms, some issues that you might see in a kid when they're having an ear infection. They might be pulling or rubbing on their ear, and they might roll their head from side to side. It can cause hearing loss, so they might be speaking more loudly, or maybe they're just not paying attention. If they have recurrent chronic ear infections, it can cause speech and developmental problems. So make sure I'm sharing my screen the way I'm supposed to. So, and we talked about what it looks like. What can you guys tell me about treating otitis media? What is some important information that you need to tell parents?
Take all of the antibiotics.
That's the main thing, is you take all of the antibiotics. Very good. So a lot of times kids will be feeling better after maybe 3 to 5 days. Antibiotics are usually for 7 days. So you need to make sure that they take all of the antibiotics. And what is the risk? What happens if the kid doesn't finish the complete course of antibiotics?
It can return.
Yeah.
Or it can never fully heal.
Yeah, and they can also create bacterial resistance, right? So then you end up with bacteria that are more resistant to antibiotics. So when they get another ear infection, it's harder to treat. Very good. And you guys said this, so make sure that you continue the antibiotics till the full course is done. So ear infections can lead to hearing impairment, and sometimes kids have hearing impairment for other reasons also. So what do you think that you should do? How should you communicate with a kid that has a hearing impairment? How should you be at their eye level? Should you speak more loudly? What should you do?
No, you should be at their eye level
Eye
and just
level.
let them watch your mouth.
Give them like a calm talking voice.
Mhm. Yeah, very good. So this is the picture here of some things that you want to do. So you want to make sure that you're eye level, face to face with the kid, and you don't want to talk in really long sentences, like nice short sentences. And you want to make sure that you don't do a lot of exaggerated movements. A lot of times they're going to be reading your lips, so you don't want to be like smiling really big or doing weird things with your eyebrows or anything like that, because that can be distracting for them. So just kind of in a calm voice, but right there, right at their eye level, go ahead and talk to them. So we're going to move on to the eyes. Who has heard of either strabismus or amblyopia? Yeah. So Danny, what do you think what are we talking about here?
One has to do with maybe a weak eye muscle that causes your eyes to kind of sort of deviate from the central center
Very
of
good.
the view.
Yep, and that's what you're looking at here. So that's strabismus, and you can see his eye here. He's cross-eyed, so he's not focusing because the muscle for this eye is weak. So how do you think you treat this?
Some surgery,
Mhm.
but maybe I'm wondering if there's some other kind of non-surgical intervention.
There is. So what they normally do is they normally actually patch the good eye.
Yeah, that's what I thought too. Cause I seen a boy and he had the cross-eyed one was like the other one was on, but it was only there for a certain amount of hours.
Yeah. Yeah. So the kids
Professor,
tend to get
I
really
got a question.
frustrated. Yeah, go ahead.
So personally speaking, if I was to cover my cross eye, my good eye,
Yeah.
my eye's gonna be fixed. Or this just
So
for children?
yeah, it's just for children. So it's when that muscle can still be developed, when you still have a chance of fixing it. So they put it on the good eye, and that forces the brain and the muscle to use the bad eye. So by doing that, they strengthen the muscle.
So if a parent was to ask, what would be the parent education if the parent was to ask if they can do it as well?
Oh, you mean if the parent has a cross eye?
Yeah, you get what I'm trying to ask. Like, what if the
Oh.
parent asks, okay, well, if I do this to my child, like, what if it's hereditary?
Oh. So honestly, like I'd have to follow up. I know when kids are little, that muscle can still be developed. It might work in an adult. Most, have you ever seen an adult that was cross-eyed? No, like most of the time it's fixed when they're kids.
Oh yeah, I didn't see the.
Oh, you have? Okay. I'll have to see, but certainly when they're little, that muscle can still be developed. So it's possible that when you're an adult, I mean, also when you're adult, it'd be harder, right? Because you have things that you need to do, and it would be harder for you to do your responsibilities if you're only able to use your bad eye. But yeah, I will find out and let you know. But for sure, when you're a kid, if you patch the good eye, then the brain automatically start focusing on the bad eye. So the strabismus is the muscle, and then one that's very similar is amblyopia, and that's visual acuity, where one eye sees better than the other eye, and it ends up being the same thing where they don't track and focus together. And the treatment is also the same, where they start with patching.
I'm trying to get my phone right.
So they can also put like prisms in the glasses to help focus or help the eye focus. And then if none of those things work, they can do surgery. Eye strain just refers to
It's echo, like an echo.
Eye strain just refers to when kids have a visual acuity problem and they're squinting and trying to see, and that could cause their eye strain. Sometimes kids that have undiagnosed vision problems, they won't do as well as school. They might have behavioral problems. They might have frequent headaches. So if you have something going on with the kid that you can't find like a specific illness or anything for, it could be something as simple as they need glasses. And then there is a condition that you need to know when you work in pediatrics called retinoblastoma, and that's a tumor in the eye. And you can see this is the kid here that has like this white reflex. So this is the eye that has the retinoblastoma. They can have problems with vision. They can have strabismus. They can have dilated blood vessels around there. That's this hyphema. So just to be aware, you know, a lot of times parents will see this before the healthcare provider. You know, parents frequently kind of really know what their kids look like. So if they ever mention to you, they kind of have this white light in their eye, you should really pay attention to it. So usually it's diagnosed pretty early. And they can treat it with photocoagulation, chemotherapy, radiation. In more advanced or severe cases, they actually have to remove the eye. Something that we talk about in terms of, you know, in nursing school, you should always be able to identify the things that are medical emergencies. So fixed dilated pupils are a medical emergency. When you see fixed dilated pupils, you know, in life, in NCLEX questions on the HESI, you should always be aware that that's something that you really need to be concerned about. So what do you think is happening inside the head, inside the skull, that would cause fixed dilated pupils?
Could be pressure due to a bleed, some type of trauma or injury.
Very good. So you're worried about increased intracranial pressure if you see fixed dilated pupils. So this slide here, it goes over all the cranial nerves 1 through 12, but in particular here, when we're talking about fixed dilated pupils, we're talking about cranial nerve number 2, which is the optic nerve. So if you have pressure on the optic nerve because there is increased pressure in your brain, that can cause the fixed dilated pupils. So that's why, you know, there isn't really anything other than pressure on the optic nerve that causes that symptom. So that's why you really have to pay attention to fixed dilated pupils. So these 2 slides, they go over the 12 cranial nerves. To be honest with you, you don't have to memorize all 12 of them. I would certainly remember the ones that you could test pretty easily, like the optic nerve is number 2. The acoustic nerve is number 8. The hypoglossal nerve is number 12. Then you test that by having them stick their tongue out. So there's certain ones that, you know, when you're doing a neuro exam, you might ask them to stick their tongue out or test their hearing on both sides, things like that. That's like a quick way to kind of check if their cranial nerves are intact.
Good question.
Yeah.
Is that why they tell stroke patients to stick their tongue out? And
Yeah, very good. Yeah, and they also, yeah, very good. So who has heard of Reye syndrome? REYE. Has anyone heard of it?
We heard about it in pharmacology.
Yeah,
Okay.
something
about
about a big
aspirin.
thing.
Okay, something about aspirin. Okay, so
Yeah.
very good. So this Reye syndrome is the reason that we recommend Tylenol or ibuprofen when children have fevers. So aspirin will also bring down your fever, but if you take aspirin, if kids take aspirin when they have a viral illness, they can develop Reye syndrome. So Reye syndrome is it causes inflammation of the liver, and it also causes encephalopathy. So they kind of can have altered level of consciousness. So the one thing you need to remember about Reye syndrome is that it's associated with aspirin, but aspirin is in the salicylate family, which is this word here. So you not only have to remember aspirin, but it's really any medication in the salicylate family that can cause the children to develop Reye syndrome. And it's, it usually when it develops, which there's a lot of education, I think very few parents give their kids aspirin when they have a fever, but when they develop it is they usually have like flu-like symptoms, like so fever, muscle aches, etc. And then they give the aspirin and they can develop the Reye syndrome. So there's no vaccine for it. There's no specific test for it. It's just this condition that tends to develop if you take aspirin when you have a viral illness. And then, so meningitis is usually infectious, but meningitis in general is just a term that means inflammation of the meninges, which are the fluid-filled membrane that cover the brain. So it's usually bacterial or viral, but you can actually have like a chemical meningitis. It's almost always infectious, but it generally speaking, the itis just means inflammation. So it's inflammation of the meninges. Children that have meningitis, they tend to have fever, chills, severe headache, nausea, vomiting. They can have a stiff neck, photosensitivity, and they can be a little bit confused. If they're really agitated or if they're having a hard time breathing, these are some more ominous signs, like it's a worse case that could be causing increased intracranial pressure, and then a bulging fontanelle. So kids where their fontanelle isn't closed yet, it might be taunt or bulging, or infants sometimes will not want to feed. They won't want to eat. So there's 2 tests that you can do, as an outpatient, if somebody comes in and you're worried that they might have meningitis. They're not definitive. It doesn't 100% tell you, but they will frequently do that before they do like a lumbar puncture or anything like that. So the first one is this Brudzinski, which is you see the kid laying down here. And what it is, the kid lays down and then they pull the head up. And when they do that, the legs flex. So that's a positive Brudzinski. And in the Kernig, they lay the kid down. And if they put the leg up in this position at kind of a 90-degree, he's unable to straighten his leg. So both of these signs, if they're positive, that's an indication of meningitis. So like I said, the Brudzinski and the Kernig are not definitive. So confirmation is made by examination of the CSF. So how does the doctor get the CSF? What procedure allows the doctor to do that?
A lumbar puncture.
It's a lumbar puncture or spinal tap. Yeah. So they do the lumbar puncture and they gather the fluid and they send it to the lab. So while they're waiting for the lumbar puncture results to come back, they're put in isolation for at least 24 hours. They almost always order neuro checks. And as a nurse, in addition to keeping a close eye on their neurostatus, you want to make sure that it's a quiet environment that doesn't have a lot of stimuli, because they can be really annoyed with lights and sounds and stuff like that. So sometimes when children have meningitis, they can have a seizure as part of their disease process. And then sometimes kids have seizures because they have epilepsy or a seizure disorder, or it can be a hypoglycemic seizure or a febrile seizure. So seizures can happen for a couple of different reasons, but there are a couple things that might be triggers for seizures. So, flashing lights, being overhydrated, which really can mess with your sodium level, are the kind of the more common ones. So not all kids who have a seizure necessarily have a seizure disorder, but once they've been diagnosed as having a seizure disorder, they will likely be on maintenance medication or some sort of chronic medication called an anti-epileptic. And you're going to make the choice about the epileptic based on the type of seizure. And there are some other atypical things, like some kids are really resistant to medications. So they might be on a keto diet. Sometimes that helps with seizures. There's vagal nerve stimulators that are sometimes surgically placed to help kids that have refractory seizures. And there's a medication that you'll see a lot on like NCLEX style questions. Has anyone heard of Depakote? So that's a common seizure med. And then another one that starts with the D, Dilantin. Has anyone heard of Dilantin?
Yes.
Yeah.
So what is something that you always teach people about Dilantin, that it's kind of an unusual side effect?
Not
So this is the only reason why I say this, because I've seen a lot of NCLEX questions. So it can cause what's called gum hyperplasia. So sometimes they'll have bleeding gums, and they'll teach parents to massage the gums to help with that. So just because there really aren't a lot of medications that has that as a side effect, I would remember that, because it tends to be something they pull out to test.
I have a quick question.
Yeah.
Like adults, do children have auras?
They can, yeah. They might have an aura. Sometimes they'll vomit right before they have a seizure. They don't always, but they can. So when you have a kid that has a seizure disorder, they're usually part of a multidisciplinary team. They work really closely with their neurologist. They usually have like a social worker or a case manager that helps to make sure they have access to their medications, et cetera. And this is the same for adults and in children. There's certain sort of responsibilities you have as a nurse when you're taking care of a patient who has a seizure disorder, making sure the side rails are up, you know, that they don't have any access to sharp objects, that they always have their medical ID bracelet on. You need to educate parents about, you know, increased risk about being around water if they were to have a seizure when they're in the pool, et cetera. If they have any triggers, to make sure they're avoiding those, and make sure they understand the importance of taking their medication as prescribed. So cerebral palsy, or CP, is something that you'll definitely see when you're working as pediatrics. Is anyone taking care of a patient that has CP or knows a kid that has CP?
My daughter has it.
Your daughter has it? And how old is your daughter now?
She's 5.
She's 5, and how's she doing?
She's doing good. It's just she can't really walk right now.
Okay,
She can't
so
really
that's,
sit up on her own.
yeah. Oh, I'm so sorry. It's hard. And I don't know in your specific case, but usually there is a problem with delivery. There's usually like lack of oxygen during delivery that causes the CP. So you know, and it tends to, you know, there's a wide spectrum. So you said your daughter isn't walking. Does she go to physical therapy? Do you think that she'll be able to walk with crutches, or is she not going to be able to do that?
Yeah, she's getting therapy, so she'll be able to do that.
Yeah.
Yeah.
Yeah, it's so you'll see kids that have CP all the time when you work in the hospital, because they don't have the same mobility. So then they're more at risk for like respiratory infections and skin breakdown and other complications, because they can't just get up and move. So they almost always are physical therapy. A lot of times they have crutches or braces. They can do like tendon lengthening surgeries to help with some of the contractures. So they get a lot of medical care when they're young. So I'm so sorry that you're dealing with it, but thank you for sharing. I think it's really important that people recognize that kids with CP, it doesn't mean that they have a problem with their mentation. A lot of times we see kids that look different, and we think that they're not as intelligent as everyone else. And there can be sometimes kids with CP do have some intellectual disability, but it's more than anything, it's really their physical mobility. They're contracted, they can't walk, etc. And you will see this when you're working in pediatrics. You're going to definitely see a lot of kids that have cerebral palsy. So when you're working with kids that have CP, you know, you want to make their time in the hospital as normal as possible. So sometimes they will have like communication boards or techniques that they can use to help them communicate. So a communication board could even be like an iPad where they can point at different pictures that mean something, or they have really fancy ones where they can look with their eyes and that will spell something on their iPad. So they have a lot of technology to help kids communicate when they have CP. And you want to encourage locomotion. That means movement, whatever, if they're in a wheelchair, if they have crutches, whatever it is, you know, try to maximize their ability to move around. And you want to play with them, you know, recognize that they're still a kid. Whatever they're able to do, you want to try to have some toys, etc., that they will enjoy, because they're still a kid, even if they have this medical problem. So It's really, really important when you're working with a kid that has Down syndrome or has some sort of intellectual disability that you just recognize that they're still a kid, that you don't, discount how they're feeling, or you don't assume that they don't want to play the way that other kids want to play. They have the same sort of psychosocial needs, even if they don't have the same intelligence. So you really need to sort of figure out what is their developmental level and then engage them with play that is appropriate for their intellectual and developmental level. So sometimes this can obviously be really, really hard for parents. So sort of help parents set realistic expectations about what their child is going to be able to accomplish, and always focus on the positive things. Emphasize to them if they're constantly failing, like if you expect your kid to be normal and your kid is not normal, then they're going to constantly feel like they're being criticized and they're going to feel like they're failing, and then that'll make them feel angry. So you really need to develop sort of the tasks and the toys and the play that you do with them that's appropriate for what their ability is. So always, every time in nursing, if you're given a question about plan of care, you always want to think about, is it individualized? You're providing emotional support, thinking of the entire family unit when you're in pediatrics. And then when they're in the hospital, trying to maintain their home routine as much as possible, and always think about their level of maturity and their ability when you're planning their care. And I talked about this a little bit, always emphasize their strength. It doesn't matter if you're wheelchair bound, you can still do a lot of things, and you should really kind of highlight those things that they're able to do. The school nurses are a great resource, and there's also a lot of support groups, et cetera, in the community that can help parents. So sometimes, we think that the way a child looks kind of determines what their abilities are, and that's not true. Like some syndromes, like Down syndrome, you can look at somebody in the face and you can see that they have Down syndrome. But a lot of times you can have like a very normal face and have an intellectual disability, or you can have some asymmetry or something in your face that looks wrong, but you're totally normally intelligent. So don't ever think that that you're going to be able to really predict someone's ability just based on what they look like. Yeah. Someone have a question? No. Okay. So when we're talking about pediatrics, obviously kids play sports. So just making sure that there are sports related injuries and concussions can happen. And you need to be aware that, when there's a concussion or a head injury, where the child either has amnesia or is really confused, that's more ominous than when they maybe are just a little bit sleepy and then they wake up and they feel better. So just kind of be aware that confusion and amnesia are bad signs following a head injury, and that sometimes you won't see problems with following a head injury for a couple days. It doesn't happen necessarily right away. It can be a couple days after the injury. So you need to make sure that parents are aware of that and are monitoring their kids for like 2 to 3 days after they've had their head injury. So there are head injuries from sports or accidents, et cetera. And then there's what we call non-accidental trauma. So child abuse, and in infants, shaken baby syndrome. So this is where you pick up your baby and you shake your baby and the brain kind of moves back and forth within the skull. So it can cause increased intracranial pressure, bleeding. So anything that you can think of in terms of what a kid would look like that had increased intracranial pressure, that's what you would suspect in shaken baby syndrome. But they might also just have vomiting, blurred vision, be a little bit sleepy, or have a headache that you would see maybe in a toddler that was just really fussy. And if it's a very bad injury, they can be completely unconscious, and you can die from shaken baby syndrome. So when we're talking about head and spinal cord injuries, there's two different posturing. There's decorticate and decurvit. So both of these are ominous signs. It's never good if your patient is posturing. So the decorticate is more associated with cervical, so the spine, and then the cerebit is more associated with the brain. So decorticate, you can remember that's the arms from a C, they kind of move in, and then to cerebit, they go out in the shape of an E. So I would recognize both of these types of posturing. And this one's spinal and this one's more the brain, and there it's never a good thing. It's always the sign that there's been a serious injury. So we're going to talk a little bit about increased intracranial pressure, which we also just call ICP. We talked about, the fixed dilated pupils. That's an indication, but there's also changes in the vital signs where you have the increased blood pressure, decreased heart rate, and irregular respirations. So that is a triad. Does anyone know the specific name of that triad that we talk about in healthcare? So that's Cushing's, Kushing. So Cushing's triad is a bad sign. So it's the three of them taken together where the blood pressure goes up, the heart rate goes down, and the respirations are irregular. So that's a sign that's probably the most common sort of sign of increased intracranial pressure. Some other things that you might see is some vomiting, altered level of consciousness, a really bad headache. But if you have a patient that has this specific triad
I'm
of
sorry.
vital sign changes.
Can you spell that for me again?
Yeah, I'll put it in the chat. It's called
Okay.
Cushing.
Okay.
And it's one of those things, right? It's not normal to have, blood pressure that goes up when your heart rate goes down. So Cushing's triad. Oh. There you go. So when you're taking care of a patient that's had any sort of a head injury or brain injury, neurochecks are really, really important, and you're going to be told how often you need to be doing the neurochecks. But just remember, as a nurse, anything that's subtly different, like you walked in the room 2 hours ago and the kid sat up right away and started talking to you and wanted to talk to you about whatever he was watching on TV, and then you come in and the kid's just a little bit slower, maybe his head's tilted to the side and he just isn't having the same level of interaction with you. Well, that's a subtle change that you need to tell the doctor about. A lot of times these changes that you see after a brain injury, it's not going to be like all of a sudden they can't use their left hand. I mean, obviously that could happen, but usually it's something really subtle that you pick up because you're really paying attention to your patient. So just be aware of that subtle changes are really important. So when you do a neurocheck, you really need to be doing a full neurocheck, checking symmetry on both sides, looking at both pupils, and then documenting anything that's different. So these are all the different types of things that you're going to be monitoring when you had a child that's had a head or brain injury. So how they respond to painful stimuli, you kind of, unfortunately, maybe you put pressure on their nail beds and you have to do it on both sides to see if the response is the same on both sides. Their level of consciousness or their level of alertness, their cranial nerve response, that'll be like their eyes, their hearing, the ability to stick out their tongue. Posturing, we talked about. Looking at their eyes, the response of their pupils, if they still have a fontanelle, is it bulging? You might see scalp vein distension in younger kids. So inability to walk normally or spasticity in their lower extremities. So all of these things are things that you need to be paying attention to. So in addition to, head injuries, obviously, you have to be careful when you're talking about kids in water. So if they have submersion that's accidental, that can lead to hypoxia, aspiration, hypothermia, pneumonia. And because of the hypoxia, it can really lead to brain damage or a brain injury. And it's the fourth leading cause of death in children. So Generally speaking, if you're submerged for more than 10 minutes and don't regain consciousness within 24 hours, even if you're still alive, it's unlikely that you're going to have a good neurological outcome. So usually after a drowning, you'll have a regaining of consciousness within a short period of time if you're going to have like a normal neurological function following the event. Okay, does anyone have any questions about that? Okay, so I'm going to pull up a quick Kahoot. It's just an 11-question Kahoot. And then we'll move on to the next PowerPoint.
I actually had a question.
Yeah, go for it.
In regards to dry drowning,
Uh-huh.
how does that like affect the neurological situation with a child
are
as
you
well?
talking about, when you're talking about dry drowning, are you talking about just like suffocation where they're not able to breathe, but they're not necessarily submerged in water?
In regards to dry drowning, it's like when children or when people take in like a little bit of water and they're
Okay.
and they're
Yeah,
not.
so like it has to be enough, like if it's just some small amount of water that got into their lungs but didn't affect their oxygen flow to their brain, like if they were still breathing, and then they could have lung damage. But if they've had like their nose and mouth submerged in water, it could still cause, and even if it's just a couple tablespoons, it could still cause brain damage.
Okay.
Is that answering your question?
Somewhat, but I guess I'll do further independent research on it.
Okay, and is there a reason why you're asking, or are you just curious?
It was a few years ago, a friend of mine, her daughter passed away from being submerged in like a small.
Okay, I'm sorry to hear that. Yeah, I mean, so generally speaking, if there's lack of blood flow or lack of oxygen to the brain, then that is more than likely what's going to cause, the bad outcome. And that
Professor,
can
I have a
happen
question
in
on
a
that
very
topic.
small amount. Yeah.
So you know how, like when you're young and you have those parents that's like, oh, I'm gonna teach you how to swim, and they just throw you in the pool.
Yeah.
So they can be the cause of like neuro damage. So I just wanted to make sure I could tell my parents this, that it's their fault.
Oh, well, I mean, if they pull them in the pool and then the kid sinks and they don't pull them out, then yes, like.
They ain't come get me. So that's probably the reason why my eyes cross like this.
Oh, no. Yeah, I mean,
Oh,
certainly,
okay.
I mean, you need to be careful around water, 100%. Like it can be, like I said, it can be like a couple tablespoons of water, but if it's around your nose and your mouth, then that's enough. And you should never just throw kids in the pool like that.
Okay.
All right, so why are infants more susceptible to otitis media? The eustachian tube is short, straight, and wide. They're always lying down. They have increased susceptibility to respiratory infections, or sucking on a nipple creates middle ear pressure. Very good. Yep. The main reason, the most important one, is their eustachian tube is not as angled. It's flatter. So a student has a generalized seizure in the school's nurse's office. At what point should the nurse call 911? If the child is sleepy and lethargic after the seizure, the child vomits at the onset, the seizure lasts more than 5 minutes, or the child is confused and has slurred speech after the seizure. All right, so very good. So there's something called a postictal phase after a seizure, which is normal. So it's when you're coming out of a seizure, it's normal to be a little bit sleepy. You might be confused. You might have some slurred speech. Sometimes kids vomit, or sometimes they could have an or at the onset. So this is the one that's really abnormal, the seizure that lasts more than 5 minutes. So if it's lasting more than 5 minutes, you're going to be worried about them protecting their airway, getting enough oxygen to their brain. So this is the reason that you would call 911. So what would the nurse include in a teaching plan about the long-term administration of Dilantin? Should be given on an empty stomach. It can cause insomnia. You should massage the gums to prevent hyperplasia, or blood pressure should be monitored closely. Right. So this is the one, this is the only medication I can think of that causes that gingival hyperplasia, which is hyperplasia or swelling of the gums. So this is something that's on a lot of tests out there, that it can cause that, and you can kind of prevent it by massaging the gums on a regular basis. So which assessment finding in a child with meningitis should be reported immediately? A slight drop in blood pressure, irregular respirations, tachycardia, or an elevated temperature. All right, very good. So that irregular respirations, that's part of your Cushing's triad, that you would worry about increased intracranial pressure. So it's normally drop in heart rate and an increase in blood pressure, so not a drop. And tachycardia also, think about bradycardia, it's normal for them to have a fever. So this is the one, the irregular respirations, that's the one that you're going to be most concerned about. So the nurse urges the mother of a 6-month-old child to get her child vaccinated with the Hib vaccine. Why? To protect against otitis media, to protect against influenza, to protect against bacterial meningitis, or to protect against skin infections. So very good. Yeah. So that Mophis B influenza, even though it has the word influenza in it, it's a bacteria, and it's it's one of the more common causes of bacterial meningitis in infants. So making sure that kids are vaccinated helps protect them against developing meningitis. Which situation would cause the nurse to suspect a hearing impairment? A 3-month-old infant with a positive Moro reflex, an 18-month-old toddler who is speaking in 1-syllable words, a 15-month-old who is babbling, or a 24-month-old who communicates by pointing. All right, very good. So a 3-month-old that has a positive Moro reflex, that's a normal finding in a 3-month-old. That's that startle reflex. An 18-month-old, 1-syllable words, that's still normal. 15-month-old babbling normal, but the 24-month-old, this 24 months, you should be using 2-word sentences. So if they're just mainly communicating by pointing, that's a red flag. So what is the best way for a nurse to communicate with a 10-year-old who has a hearing impairment? Let the child's parents communicate for her, recognize the child would communicate at a 6-year-old level, use gestures and signs as much as possible, or face the child and speak clearly in short sentences. Very good, you guys. Yep, you want to make sure that they can read your lips, so clearly short sentences at eye level. So what might the nurse explain as a common treatment for amblyopia? Using corticosteroids to treat inflammation of the optic nerve, patching the affective eye to allow the refractory muscle to rest, using glasses that will slightly blur the image of the good eye, or patching the good eye to force the brain to use the affected eye. Very good. You're going to patch the good eye. So what information should be given to parents to prevent Reye's syndrome? Test the child for Reye's syndrome if they exhibit fever, vomiting, or lethargy. Use aspirin instead of Tylenol. Encourage immunizations against Reye's syndrome, or avoid giving salicylate medications when child has viral symptoms. Right, very good. So the salicylates, this is a family of medications that aspirin is in. So that's what you need to do. Advise parents not to give that if their child has a viral illness. All right. Who's TT? All right, very good, Tiffany. And then Mo, who's Mo?
I am.
Yeah, and Lena is probably.
I
Cool.
am.
Very good. Thank you guys. So I'm gonna pull up the next PowerPoint for the next chapter. Let's see here. So you guys have an option. Do you want to take a quick break, or do you want to power through to the next PowerPoint? Who wants to take a 10-minute break? No one wants to take a break? You'd rather power through? Okay.
Does that mean we get out early today?
It might be a few minutes early. You have to take your quiz at the end, but yeah.
Quiz.
Yeah, quiz. All right, so this is chapter 24, the musculoskeletal section, or child with musculoskeletal conditions. So there are 70 PowerPoint slides, and we don't have time to really go over all of them. So we'll go over most of them, but I am going to jump ahead to the 5th slide to start with. You guys have this as a reference point, but I will make sure that I point out things that are the most important. So the musculoskeletal system is going to be the bones, the ligaments, the tendons, and the muscles. So what do you think is different about the bones in children versus adults? Like, who's more likely to get a fracture when they fall, an older adult or a kid?
Older adult.
Older adult, yeah. So kids, their bones are a lot more pliable. They have a lot more bend. They're not as brittle. So they're less likely to have a fracture. This picture in the upper corner here, this shows a long bone. This would be something like your femur. And the head of this part here, the epiphyses, this is where the growth plate is. So if they have a fracture in this top part of the bone, that can affect the ability of that bone to keep growing longer. So you worry about fractures in the epiphyses. And this longer part here, diaphyses, they can still have fractures here, but it's not normally something that you worry about. They might, need to have, cast or surgery for the fracture, but it's not going to affect the ability of that bone to grow. So the growth plate is up here. So you always worry more if they have a fracture in that upper part of the bone. So generally speaking, just to be aware that when you're talking about musculoskeletal, it's both the muscular and the bone or the skeletal system. They develop at the same time in gestational life, and they really work in concert with each other. So when you're doing an assessment of the musculoskeletal system, you want to be paying attention to how a child walks. So for example, sometimes kids that have cerebral palsy, they have a lot of extra tone and they walk on their toes. So they can't flatten their feet out. So they have an abnormal gait. And you want to be touching things and then range of motion, how they're able to move. Sometimes parents worry when they see their kid walking, because kids, when they start to walk, when they're toddlers, they're kind of short and squatty and low to the ground, and they can kind of waddle back and forth. So that's normal. That's how kids, that's just their body shape when they're that age. So you don't really expect them to be walking, 1 foot in front of the other and swinging their arms until they're around 4. Or I'm sorry, until they're 6, but they can start hopping when they're 4. So just make sure that parents know that it's normal if their child doesn't have like a normal adult gait, and usually it gets better over time. And this is just reinforcing that educate parents, unless they're having some pain or anything like that, their gait will more than likely improve as they get older and more balanced. So just like when we were in the other chapter talking about the neuro assessment, you always want to be paying attention to symmetry. Is it the same on both sides of the body? And paying attention to tone, presence, absence of spasms are all different techniques that you use when assessing. So there are obviously like radiographic studies that you can use to look. And then there are some laboratory studies. So this is CBC. You're going to see this a lot. This is your complete blood count. But the ESR, both of these, if you're worried that there's like pain related to an infection, it would be likely to get both a CBC and an ESR. And these are just some treatments. I don't think there's anything on here that would be new information for you. So we talk about soft tissue injuries. So, and I'm pretty confident that you've heard this in other classes. So this is the acronym, the rest, ice, compression, and elevation. That's ICE. That's for your sprain and your strains. And you do need to remember that to have like an idea how you would treat soft tissue injuries. So when we talk about soft tissue injuries, these are the 3: contusion, sprain, and strain. Who can tell me the difference between a sprain and a strain? It kind of says on there, but tell me what you think. You fall and you twist your ligaments. So what does the ligament connect?
Is it muscles to bones or bones to bones? One of those.
LB. So ligament is connecting. I always get these two. I'm pretty sure ligament. Huh?
Is it tendon?
Tendon. What?
I don't know. I just know. Is it tendon?
Okay. So tendon connects muscle to muscle, and ligaments connect bone to bone. So you have these 2 fibers in there. And so I'm sorry, I said it wrong. Tendon connects muscle to bone, and then ligaments connect bone to bone. So you have both tendons and ligaments. So you do need to be able to recognize, because like a tricky way to tell you this would be like Johnny tore his ligament, and you would have to be able to recognize that that's a sprain versus a strain. So you do, like, they might put these words on the test and like test your knowledge of which one is which based on if it's a ligament or a tendon. So I would pay attention to these two things here. But regardless, if it's a sprain or a strain, you're going to do the rest, ice compression and elevation. And then you want to, if, you know, soon after they fall or hurt themselves, you want to provide immediate treatment. And then, you know, continue to monitor them to make sure that they don't need to go in for like an x-ray or anything like that. So, you know, just generally speaking, you know, when you're talking about musculoskeletal injury, it can be accidental, right? So making sure that you're talking about helmets, car safety, safety around water, locked doors, all of these things. So those are the soft tissue things. And then beyond soft tissue, you can have actual bone damage. So these are, you know, a bunch of different types of fractures, but I want to point out a couple of them to you. So does everyone see this one in the corner here that says spiral and it has the blue arrow?
Yeah.
So spiral would be like a way to do this is someone grabs the bone with hands and they twist in opposite directions. So this type of fracture is associated with child abuse. Like you can imagine that if you grab a child's arm and then you twist it and you twist it so hard that it causes a fracture, that's child abuse. So this one specifically is associated with child abuse. So if you ever see a spiral fracture, you have to have on your list of differential that it could be child abuse. And this one here is compound. So what do you guys see about the skin here? What does this look like?
It's broke.
Skin is broken, so it's
Yeah,
It's
the
like an
skin's
even
broken.
broke.
Yeah, and you see this bone sticking out. So this is, you know, this is going to require surgery. And what do you think they're at risk for because the skin is broken?
infection.
Infection. Okay. And then this one is simple. This is going to be this is the epiphyses where your growth plate is. This is the diaphyses where it's just the long part of the bone. This is just a simple fracture. This, you know, very likely this would not require surgery. They would, you know, you can see that the bone still meets at the right place. They would immobilize that and this would just, the bone grow back together. And how about this green stick here? What do you see on this green stick fracture?
Because they're kids, their bones can bend and break.
Yeah, that's true. So when you look at this on the green stick, does the fracture go all the way through the bone?
No.
It looked like it just like chipped. almost.
Yeah, very good. Very good. Right. So this is not a complete fracture. It's, you know, the bone is fractured, but it doesn't go all the way through. So this is another one that would be they would probably just put a cast on there and this would grow back together. So, you know, generally speaking, there's an accident. It could be either accidental or non-accidental. In the case of child abuse, they're going to have pain, tenderness. We've talked about fractures heal more rapidly in children. And the epiphysis, this is where that growth plate is. So injury to that can cause problems with growth. It's more serious. It's a repeat of other things that we've said. So we're going to talk a little bit about traction. Have you guys talked about traction in like your med surg class or had any conversations about traction before? Yes, no?
Yes.
Yes, okay. So what can you tell me some basic nursing interventions for a patient that's in traction? Regardless of the type of traction, what are some things that you do as a nurse?
You want to check the skin integrity.
Check the skin integrity. Very good. What else are you checking?
Blood flow.
Circulation.
Circulation, perfusion, pulses, sensation. Very, very good. And how about the weights? Where are the weights?
They should be free hanging.
They should be free hanging. They should never be on the floor. Okay. So many times, I think almost always in adults when they're in traction, they use what they call pin traction, but there's actually a metal pin that goes into the bone. So for kids, you know, especially like little kids that don't really weigh that much, they do skin traction, which is they wrap something around the bone and they hook that up to the weights. So this kid that's in Bryant's traction, there's nothing poking in, there's no pin. You can see all of this wrapping, and then this wrapping is what's hooked up to the weights. So Bryant's traction is for fractured femur, and this is children under the age of 2. So there's a couple different types of fractures that we are going to talk about today. You need to remember the age group. So Bryant is young child under the age of 2. And this is kind of the position that they would be in. They would be laying down with their legs in the air, and then the weights are over here. Whereas Buck's traction is going to be an older child, and you can also use it for a femur fracture. But you can see here it's also wrapped, and then the weights are connected here. You can't really necessarily see it, but the heel's a little bit elevated, but the leg is on the bed, and it pulls the femur into alignment with the weight here. It pulls the leg away. So something that you have to think about with Buck's traction is, and also with Bryant's, they can never not have their head or their bed elevated. So they can't be in a high Fowler's position, because then they won't be able to maintain the position of their leg. So they always have to be in a semi-reclined position. So in addition to using it for a femur, they can help reduce muscle spasm and pain with this condition that we're going to talk about in a little bit, called the slipped capital femoral epiphyses, which is just when the femur head is slipped out of the socket.
So you said that Bryant's is under age 2?
Yeah, Bryant's is under age 2 and Buck's is over age 2. Yes.
Okay, all right.
And there's one that's not talked about as much that's called Russell. So Russell and Buck's are both older kids, and this is not the best picture in the world here, but you can see in Russell, they put a sling around the knee and they elevate the leg. So in Buck's, it's on the bed, and then in Russell, which is this one here, they've put these slings on. But it's the same thing where the leg is extended and then the weights hang off the side of the bed. Whereas in Bryant's, it's the little kid and their legs are straight up in the air, and the weights are hanging off the bed. So this is, you guys have talked about a lot of this. So the weights are hanging freely, and then the bed linens are not traction ropes. So, and you're going to be monitoring them closely. There are multiple things that you would worry about in terms of the effects of traction, right? So they can't be totally flat. So they're going to have decreased lung expansion. So you need to make sure they have an incentive spirometry, or they're doing some deep breathing exercises. They could have muscle wasting because they're not moving around. They could be retaining urine because of their immobility, tissue breakdown, increased risk of clot, develop constipation. So you need to be thinking about, treating all of those things or preventing those things if you have a patient that's in traction. So, this is going to be something you'll see again. They can't be sitting up, right? They have to be no higher than 20 degrees or you won't be able to maintain their leg in the correct position. And even in the one that's straight, which is the Buck's, the heel is a little bit elevated from the bed. You want to make sure that you do range of motion exercises, the anti-embolisms, the stockings or heparin or something. You're going to do your neurovascular checks, skin integrity, good pain control. And then if they're old enough, you might have a trapeze, something for them to hold on to, and then, making sure that you have a bowel regimen for them. So you've undoubtedly talked about this. One of the most important things that you do for traction is the neurovascular checks. And you're going to be looking at pulses, color, cap refill time, the warmth, movement and sensation. So what can you guys tell me? What's a normal cap refill time?
Less than 3 seconds.
Yeah, very good. So if it's prolonged, what are you worried about?
Impaired circulation.
Yeah, very good. So you can use traction for femur fractures. A lot of fractures, I'm sorry, don't require traction. So then you would just be doing like a cast or a splint. So even if it's just a cast or a splint and they're not in traction, you still need to be paying attention to skin integrity and something called compartment syndrome, which is the progressive loss of tissue perfusion because of increased pressure from the cast. So this would be like looking at are they able to move their fingers? Do they have normal capillary fill? Do they have normal sensation in the fingers, etc., or toes, depending on where the cast is. All right. So there is an infection that kids can develop called osteomyelitis. So this is an infection of the bone. We talked about that compound fracture where like the skin broke and the leg was open. So certainly if you have some sort of an injury like that, you're a setup for osteomyelitis. You can get infection in your bone. It doesn't even have to be that bad of an injury, just like falling and really hitting the bone hard. And sometimes they don't really know why kids develop osteomyelitis, but they get bacteria into their bone. So they usually present with fever and leg pain. So Staphylococcus or Haemophilus influenza, this bacteria that we talked about is protected by the Hib vaccine, are the most common organisms. And like I just said, it can be like a local injury or one of those open fractures where the skin breaks. So they're at risk for, complications like thrombosis and muscle spasms. They require a lot of antibiotics. One of the main things you need to remember about these kids is that they'll be on antibiotics for like 6 to 8 weeks, and it's IV antibiotics. So they almost always go home with a PICC line. When you're doing the initial workup, we talked about this a couple slides ago, this ESR, that's the erythrocyte sedimentation rate. This is a marker of inflammation. And when it's high, when the white cell count is high, you're more worried about an infection or an osteomyelitis. A lot of times you won't see anything on the x-ray, so they might get a bone scan. So in addition to the long-term antibiotics, if there's pus, they might have to have that drained. You need to be doing like range of motion. It's painful. So you need to make sure you're on pain control and that you're thinking about play therapy. That's the only real infection that we're going to talk about in this musculoskeletal section. There are a couple of conditions, musculoskeletal conditions that kids can be born with. So has anyone heard of muscular dystrophy?
Yes.
Yep. So you can see some kids here in the pictures, they have muscular dystrophy. So Duchenne's is the most common, but there's also Becker's, which is very similar, but it tends to progress more slowly. So what can you tell me? What do you think muscular dystrophy is, or what do kids look like? What's wrong with them when they have muscular dystrophy?
I don't know too much about it. I just know it has something to do with the development or lack of their muscles.
Okay. So very good. It's progressive. So it's progressive muscle weakness. It's usually diagnosed sometime around age 2. So they tend to be really clumsy. They fall a lot. They don't really have the same ability to walk. So this is one of the reasons, we talked a lot about like at a year, you should be taking your independent steps. Certainly by 18 months, if you're not really walking by yourself, you need to start thinking that something's wrong, and that something that could be wrong could be muscular dystrophy. So it's progressive muscle weakness, and you really see it the most in little kids with their inability to walk, or this kid, he's fallen and he can't get up. So they kind of put themselves, this is called Gower's maneuver, and they can't just push themselves back up, so they have to get on all fours and then grab onto something to try to stand up. There can also be an element of intellectual impairment. You're going to need to do a muscle biopsy to definitively diagnose it. And like I said, it's progressive. So usually, like I would say in the 20s, is when you really start seeing people die from muscular dystrophy, and it's usually related to cardiac and respiratory failure. So they have, you need your muscles to breathe, and your heart is a muscle. So over time, you just get general weakening of your cardiac and respiratory system, and this is usually what causes their death. It's not uncommon for them to be trached and on ventilator support. So there's no cure. There's really nothing that makes muscular dystrophy better. It just progressively gets worse over time. So there's a lot of supportive care, a lot of education for the parents. Obviously, it can be depressed because of it, because they're not going to be able to do the things that their classmates, et cetera, are able to do. So this muscular dystrophy that we just went over, this is congenital. This is like a genetic defect that runs in families that children can be born with. This next diagnosis that we're talking about is not congenital. This slipped femoral capital epiphyses, this is just where the femur socket slips out of the hip, or the femur, or the femur head slips out of the hip socket. And we talked about this as one of those things that you may treat with traction. So you'll see Buck's traction here is sometimes used to treat this condition. Usually happens in adolescence, during a rapid growth spurt, and it's not related to trauma. They're growing really quickly, and then the femur head just kind of slips out. It usually just gets better on its own, but if it's causing problems, you can do this Buck's traction to help pull it back into place. And another thing that you can see in adolescence is this leg cap perthes, and this is where you actually have lack of blood flow to the femur head. So it can cause damage to the femur head because of the lack of blood flow. It's another thing that they don't really know what causes it. It usually just gets better on its own. But in very rare cases, they might need to have a hip replacement surgery because there's so much damage done to the head of the femur because of the lack of blood flow. So kids that have this, they'll have like a limp, they might have limited range of motion in that leg. And like I said, it almost always just heals spontaneously on its own, but in severe cases, they might have to have a hip replacement surgery. So we're going to talk about a couple different types of cancer of the bone. The first one is osteosarcoma. Kids that have had other types of cancer and undergone radiation therapy or had a retinoblastoma have a higher incidence of osteosarcoma. And it is a cancer that's prone to metastasis, so it can spread to other parts of the body. The most common site is the lungs. So this one, they almost always take out the bone that has the tumor. So the treatment is the resection or amputation. So this is the one where as soon as they see it, they'll likely do an amputation of the bone that has the cancer, which is different than Ewing sarcoma, which is another cancer of the bone. But this one, they usually do more traditional radiation and chemotherapy, but not necessarily amputation. So we think about arthritis as being a disease of the older adults, but there is an autoimmune condition called juvenile idiopathic arthritis, or JIA. So this is a pediatric form of arthritis. It's an autoimmune mediated problem. So it has exacerbations and remissions, and it's usually treated with your traditional autoimmune drugs like prednisone. So, there's it can present in different ways. So systemic or acute febrile, systemic meaning multiple parts of your body. So a really high fever, this is like the common rash that you see when it presents as a systemic inflammation. And then poly and POW are articular. This refers to the number of joints involved. So poly is more than 5, and POW, I think it says in here, is more than or less than 4, but I think it makes more sense to say less than 5. So poly is the one where there's multiple, more than 5 joints involved. So when they present, they usually have these very, very high fevers around 103, and the fevers persist for multiple days. It's not like they have a fever for one day and then they feel better. So high fevers for like 10 days, this typical rash that you see here. They might also have abdominal pain. And then both of these, the ESR and the C-reactive protein, these are markers of inflammation. So they would be elevated. And then the polyarticular, this is fibromoid joints. You have them on the hands and the feet. And it's very painful. It's swollen, tender, and warm. And you see it more in girls than in boys. And then POW is the one that has fewer joints involved. You might see it more often in younger children under the age of 3, still more often in girls. And you might see inflammation of the iris when it's this limited number of joints, but they still have the same problems, pain, swelling in the joint, but they also have the photophobia and decreased visual acuity. So your ultimate goals are just going to be, making sure they have as much mobility as possible, decrease the pain, and as much independent functioning. So sometimes it's bad, sometimes they can end up wheelchair bound, unable to walk. It does have these periods of remissions and exacerbations because it's an autoimmune disease. It can have triggers. So, getting sick might trigger a flare up. So helping the parents recognize that it's chronic, etc. And they're going to be on long-term therapy, lifelong illness. So torticollis, this is when your neck is kind of stuck to the side. So congenital, you're born with it or acquired. And what do you guys think? Do most of these kids need surgery, or can you normally stretch the muscles to get their head midline?
I kind of feel like it might be surgery because you don't want to mess with their ability to ambulate if you mess around near that C-spine area.
Yeah, so I like your logic. So you don't want to do, you don't want to hurt their spine, but you can do passive range of motion, especially when they're a baby. So if you're holding their head to the side, you can get them into physical therapy and do stretching, and usually that'll fix it. If it doesn't, if it's not just passive range of motion, then they do need surgery. So, yeah. And then we're going to talk a little bit about scoliosis. So scoliosis is just this lateral curvature of the spine. And you see this more in girls than in boys. And who knows how you screen for scoliosis?
Like bend them over and walk down their spine.
Or just stand up straight.
Not walk down, but
yeah, someone. Very good. So you stand up straight and then you lean down to touch your toes. So you usually have them pull their shirt up so you can look at their entire spine. And you can see here, it can also affect their hips and their shoulders, right?
Yes.
So
my daughter got a full spinal fusion at 14.
Oh,
so
we're just going to talk about that. Yeah.
Titanium rods.
Oh,
and it was
goodness.
weird because she didn't she didn't start puberty until after the spinal fusion. So
that's interesting.
So she was like kind of
oh, wow. And is she doing okay now?
Oh, she's doing great. Yeah.
Yeah. So, it rarely can be caused just by poor posture. But that's not the most common. Usually there's a problem with the vertebrae that causes the scoliosis, and that's referred to as structural. So in terms of needing surgery, it's kind of divided up into different categories. So mild is considered up to 20 degrees. And when we talk about degrees, we're talking about the degree to which the spine is curved. So mild is up to 20 degrees, and this is physical therapy exercise. And then 20 to 40, they're required to wear a brace. And then over 40, that's when they do the spinal fusion surgery. So I would remember how to differentiate between mild, moderate, and severe, and know when they do the spinal fusion. So greater than 40. So when your daughter had the surgery, was she in the hospital for a while?
She was in the hospital for about 5 days,
Okay.
but
Yeah.
she was getting out of the bed at like late into day 2.
Oh, good.
Like she was moving pretty fast. But I was like,
Yeah.
when you see that your child's spine, when you see it on the x-ray that it's a whole S shape, and
Yeah.
she had like her shoulder was this way, but we
Yeah.
had to wait a while before they did the surgery. But it was pretty incredible just to see like the
How much?
scars and the
Yeah, it's a big
recovery.
surgery. They can lose a lot of blood. I'm glad she was
Yeah.
only there for 5 days, because it can be a really, it can take a while to recover. So I'm glad she did well. Did she ever try wearing the brace, or did they go directly to surgery?
We did try the brace, but it just
Okay.
seemed to get progressively worse. And I really appreciated Children's Hospital because we gave everything before the surgery. So plasma was donated, blood was donated. She
Oh,
donated
wow.
her own blood
Oh, very good.
so that we wouldn't have to go into the bank for anything.
Oh, wow. That's awesome. Well, I'm glad she did well. I've taken care of a lot of spinal fusion patients, and it's always really rewarding because it's one of those surgeries, they are so much better when they come out, and it's so good to be able to see them and they can sit up and they feel better. It's amazing. So, we're going to do a little bit about sports injuries. We talked briefly about concussion in the neuro chapter, but they can have sprains and strains, muscle cramps. I would recognize this word stinger. We talk about stingers most often with like baseball players, where they have repeated like injury to their fingers from catching a baseball. So they can get like an injury to the nerve network of their upper extremity. And I think about it most in terms of the fingers. So there are obviously certain sports where you're more likely to develop injuries. So unfortunately, when we're talking about musculoskeletal, we have to, just be aware about domestic violence and child abuse. So violence can cause damage to your, musculoskeletal system. Just to always remember there's both abuse and neglect. So physical harm versus, omission of care or not providing appropriate care. And there's emotional, sexual, and physical, and there's abuse and neglect for all of those subcategories. So, a lot of times students worry that if they report that they could get in trouble. So if you're reporting in good faith that you cannot be criminally prosecuted. And you just need to know wherever you're practicing as a nurse, know your state laws, but every state requires nurses to report. So you're what's called a mandatory reporter if you suspect abuse. Once a report is made to Child Protective Services, they tell the parents that a report's been made, and then they are required to visit the home within 48 hours if there's concern for imminent danger, or 72 on the higher end. And like I said, healthcare workers are mandatory reporters in all states. So, if you're ever, the nurse for a child who's been abused, and you're helping them, help them with coping skills, making sure they get the support that they need, psychosocial counseling, helping them develop problem-solving skills. So I guess what I'm saying is that like the nursing care doesn't end once the abuse is diagnosed. There's a lot of care that they need after the diagnosis when they're kind of in the recovery phase. And then, there's certain things that you need to look at that should be like red flags. So if it's hot outside and the kid's wearing a bunch of clothes, maybe the kid's wearing a bunch of clothes because the parents are trying to hide signs of abuse. Certainly like looking in their eyes and see if you see any blood spots. Irritation to the genital area. I mean, it could just be diaper rash, but you need to, spread the cheeks and really look in there and see if you think that they've been penetrating the child in any way. Dirty clothes, always paying attention to what the bruises look like. So, bruises in various stages. This one here kind of shows you. you know, when you first develop a bruise, it's just kind of swollen, and then it becomes red or purple, and then it becomes green, and then it becomes yellow, and then it becomes brown. So you are always more worried if like a child has multiple bruises that are in different stages of healing, because that means the child has had multiple days when they've been bruised. And the other thing to think about, you know, when a child falls, they usually fall forward. So having a bruise on their knee is not that uncommon, but you don't normally fall backwards. So it would be weird to have bruises on your back. So always think about, does like the pattern of injury that you're seeing fit with what the parents said happened? Does it seem logical? And do the bruises look like they're in various stages of healing? So as in all things in healthcare, you have to remember to be culturally sensitive. Does anyone know of any cultural techniques that might on the surface look like child abuse, but are just normal cultural practices?
Well, I know for me, being in the northeast section of Philadelphia, there's a lot of Russian, it's a large Russian community. So a lot of times they come off a little bit more stern, a little bit more somewhat colder than other people. And I noticed that they are uh, very strict with their children.
Okay.
And
Yeah.
yeah.
Well, that's a good thing to notice, but that doesn't mean they're beating them, right? They could just be strict, but so it's good to pay attention to. And then has anyone heard of cupping or know what cupping is?
It's a respiratory thing, right?
Yeah, so they use cups on the back. They put pressure on there and it can leave marks. I'm honestly not sure. I mean, you do cupping, like pounding on the back for like helping
Oh,
relieve
you're talking
secretion.
about when they light the fire and then kind of put it
Yeah,
under there.
they put like, yeah, and it's like to help pull out toxins is what they believe. But it's, you know, it's not a medical practice. It's just a cultural practice, but it can leave the marks of the cup on their skin. So that's not necessarily child abuse, right? The kid's not being hurt, but it will leave like a weird pattern that you wouldn't expect to see. And a student told me once about, they called it ribbing, like rubbing like a coin on a child that's been heated up a little bit to try to pull out toxins. So these are, you know, strange things that you might see. So if you see something that doesn't look right, you know, you need to consider child abuse, but then also ask them, you know, what happened here? And there might be an explanation that has to do with their cultural preference that you would have never guessed. So that is the end of the musculoskeletal system. Does anyone have any questions about this?
Professor, I have a question.
Yeah.
Are you going to release the notes today? Because my service was skipping through the class a lot.
Okay. Yeah, I will post the lecture, and do you have the PowerPoints? I can send them again if you don't have them.
Yes, ma'am. I have the PowerPoints actually printed out.
Okay. Yes. I will post the lecture today.
Thank you so much.
You're welcome. Let me find here we go. So here's your next Kahoot here. Okay. So what intervention will the nurse caring for a child in Buck's skin traction implement? Assist the child to be pulled up in bed, maintain child's feet against the foot of the bed, keep the child's heel on the bed surface, or keep the child in the high Fowler's position. So this one I think is a little bit tricky. So they might slide down a little bit, so you might have to pull them up in bed. So in terms of, you don't want the foot against the foot of the bed in, your heel's always going to be up. It's not, it's never going to be on the bed surface. Even if the leg is, the heel is up a little bit. And then you don't want them in high Fowler's because then they would slide down too much. So what is a normal capillary refill? 4 seconds, 6 seconds, 5 seconds, or 3 seconds? Very good. I'm glad you guys by and large knew that. So that's part of your neurovascular checks when you're in traction or if they have a cast on. What findings would the nurse assessing the neurovascular status of a child in Russell traction report immediately? Capillary refill less than 3 seconds, ability to wiggle toes, skin that's warm to the touch, or bluish coloration of the skin. Very good. So, these other things are normal, like they have a refill of less than 3 seconds, they're wiggling their toes, it's warm, but if it's blue, then you're worried about perfusion and you need to report that immediately. So which observation would lead the nurse to consider child abuse when evaluating a child who fell down the stairs? The mother is very anxious for her son to get medical attention. You see red, green, and yellow bruises on the body. The child broke his arm last year, and according to the mom, is accident prone, or bruises are noted on the head, arms, and legs. All right, good. So this varying stages of healing. The red, green, and yellow, that would be unusual if they fell down the stairs at one time. Then the bruises should all be at the proximate stage of healing. You might see bruises all over the place because you hit a bunch of places when you fell down the stairs, but this is the one that you're worried about multiple accidents or non-accidents where they've been injured multiple times because their bruises are in different stages, they're different colors. So what would the nurse consider an abnormal finding on a musculoskeletal assessment of a 4-year-old? They appear to have flat feet. They walk on their toes, swings arms when walking, or has an inward turn knees when standing. So a couple of you, I probably didn't go over this. So it is normal when they're kind of young and they're haven't really hit the school age yet. Their legs will straighten when they kind of start growing taller, but walking on their toes, that's the sign of mild CP. So you would expect them to be walking on flat feet. So if you see a kid that's toe walking, you need to be concerned that there's something wrong. So what nursing action will significantly decrease the risk of serious complications for a child in Bryant's traction? The child's buttocks are resting on the bed. Neurovascular checks are done frequently. Bandages are wrapped tightly. The child is restrained and unable to wiggle or move. Right. So the most important thing is you can prevent complications by doing your neurovascular checks. A nurse cares for a child in buck traction. Which observation requires immediate nursing intervention? Ropes are on pulleys. The head of the bed is elevated to 20 degrees. Child's heels are placed firmly against the foot of the bed, or the weights are hanging freely. Yeah, so you don't want the heel firmly against the bed. It needs to be a little bit elevated, so that when you put the leg on the rope or the weight, then it's able to move it. If it's firmly against the foot of the bed, you're not going to be able to realign the bone. So a child with JRE has swollen knees and ankles, a temp of 38.8, and abdominal pain. Which type of JRA is this? Common, systemic, chronic, or psoriatic? Right, so that's the systemic. Thinking about the fevers, abdominal pain, it's not just the joints, that's systemic. So Bryant's traction is reserved for children who weigh less than 30 pounds. Is that true or false? So yeah, so I put the weight in here. So this is the one that's for the kids under 2. What should the nurse include in parent education about the long-term effects of leg cap Perthes disease? Degenerative arthritis may develop later in life. The disease is self-limited and requires no long-term treatment. There are no long-term effects, or there is risk for osteogenic sarcoma in adulthood. So yeah, this is the one where it's usually self-limiting with no long-term effects, but they can develop degenerative arthritis. They might need a hip replacement later in life. All right, dun 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 dun. All right, who's SL?
Me.
Ah, very good. Congratulations. So good job, everyone. I'll post a total of 3 Kahoots, one that we didn't look at that you guys can practice at home. So the only thing left, does anyone have any questions?
Professor, can you please send those slides again?
Is this Murata? I got a message from Murata Hale. Is somebody
Yes,
else
it's me.
missing the,
Oh yeah,
that's you?
I didn't.
So you need the slides? Who else needs
Yeah,
them?
I didn't get them.
Everyone in that opposite shell.
Okay, I'll send them again.
Whenever you send anything, that shell, we don't receive it all. It
That's
only
so
goes.
weird.
Yeah, it only
Yeah.
goes to your main shell. We don't get it.
No, I went
received
into,
it.
yeah, I went into both shells. So Anisha didn't get week 4. Okay. So I think that, I mean, I'm not sure what happened. I'm happy to send them again, but I can send Anisha's also for week 4. Okay.
I didn't have them for week 4 either then.
Could you just tell me your name?
Yes.
Okay. So the only thing left for you guys to do is the quiz, which I need to turn on. So I'm going to go ahead and give you a 10-minute break. So it's 10:40. Go ahead and come back at 10:50 Eastern time, and your quiz will be up for you to take. Okay.
Okay.
Where are you guys seeing this quiz? This is gonna be quiz 3, right? Because I don't see it at all.
It's not open yet, Danny.
It's not open yet.
Oh, I thought I would at least see quiz number 3
Mm-mm.
in my modules. I don't even see that.
Nope.
Okay. Thank you.
Professor, I also don't have a week 4 PowerPoint. This is tiny.
Okay, thanks everyone for coming back and flipping your cameras back on. I'm just gonna wait a few seconds. A couple people are still turning their cameras back on. Thank you, everyone. Everyone's smiling faces. Okay. So for those of you that are back, you can go ahead and take your quiz. And when you're done with the quiz, you can just go ahead and log off. Unless you have any questions, then you can stay on and ask me when you're done with the quiz.
Okay, thank you.
You're welcome.
I don't see the quiz.
Did you log out and log back in?
Yes.
Should be there.
Let me try again.
Okay, what's your name? Just so I can go in and look.
Daphne Thompson. I'm gonna go on my computer.
Okay, I'll find you just a second.
I got it.
Oh, got it. Okay, thanks, Stephanie.
Professor Brunel, I somehow can get to the screen that I need to be on. I'm still stuck in Kahoot.
Okay, you can open a new tab.
I can't. I tried that right now.
You can try. Let me stop sharing my screen and let you share your screen so I can see.
Okay. Can you see me now?
Hold on just a second. No, did you click screen share?
Here. You can see me now, right? Oh goodness. Can't.
Yelena. Well, Yelena, could you just hold on and let the rest of the students take the test, and then you and I could do that in the second.
Okay.
I don't want to disturb them.
I think I'll figure it out.
Okay.
Better now. Thank you.
Sure.
Are we allowed to leave, Professor?
Yep, when you're done, you can just log off.
Have a great rest of the day.
Thank you, you too.
Thank you.
You're welcome. Have a good day.
You too.
Same as for now. I'll be off. Thank you so much.
You're welcome. Have a good day.
You do the same.
Hi, Anisha. I sent you a couple messages, but you can go ahead and just talk to me too, since you're the last one. Oh, you're on mute.
Okay, sorry. I was
There you
just
go.
trying to wait. Um, I was gonna say when I had looked at the announcement, I didn't see where the exam 2 was attached to the
Yeah, let's take a look here.
the
Let me take a look
the
here.
review schedule.
Yeah, let me look here. I make mistakes all the time, so I don't doubt. Let me just pull it up here though. And then let's see here. Exam to review schedule.
Oh, never mind. I
Did
think
you
I may
find
have
it?
found it.
Okay, it's kind of
Yeah,
small
I
there at the
think
bottom. Yeah.
I don't have to go in and open it that other way. Yeah, never mind. I think I remember now. I couldn't open it. I had to I don't know. I guess the way that it's set up now for us to open PowerPoint, we have to go through like our email or something.
Oh no, I mean I could email it to you if you want. I'm happy to do that because
It's
and I
okay.
changed it. I changed it as to a PPT because I think you're the one that told me you were having a hard time opening the PPTX.
Mm-hmm. And I was just wondering, like, when were you free? I just want to know which ones I had missed on my
Sure.
exam.
Yeah. If you let me know. So I have a student today at 2:30 Eastern and a student tomorrow at 5 p.m. Eastern. But other than that, I'm free in the afternoons, both today and tomorrow up until like 6 p.m. So I don't know if you're free today or tomorrow. If not, we could do Friday.
Okay. I think I would have to, I could probably try to do today.
Okay.
Let's see.
What time today? Just because I'm doing it, I have to like go in and look at your questions. So I would need a few minutes. What time are you free today?
Well, I'm free for like the next, it just depends on whenever you're able to. Like, 'cause I know I'm about to probably get ready to go to work, but I know I'm free
Okay.
for like the next, like a few more minutes or like the next hour.
Okay. Why don't we just jump back on the same Zoom in like 15 minutes? That'll give me time to pull your exam and get the questions downloaded that you missed.
Okay.
Okay. So it's for me, I always have to look at the clock here because I'm in a different time zone. So it's 11:06 right now. So why don't we say 11:20 and then
Okay.
just jump back on at 11:20 and I'll have your stuff ready for you.
Okay.
All right. Sounds good. I'll see you soon.
Thank you.
Bye-bye.